Good morning, everyone. Thank you for joining the webinar from WeSonic Lion Project. This is Mandy from WeSonic, which is the innovative professional manufacturer of ultrasound with the clinically focused solution. And today, together with WeSonic, we are very pleasant to invite the Nepal's Association for the Study of Pain to be the academic partner today. And also, very thanks to our channel partner, NS Biomedical, to offer the machine for demonstration. So, Mr. Nagendra, as the representative of NS Biomedical, would you like to say something here?
Yeah, thank you, Mandy. Namaste. I'm Nagendra Shrestha on the behalf of NS Biomedical, Kathmandu, Nepal. We are honored to co-sponsor today's webinar with the WeSonic Medical. Many of you have a huge effort to join us today. We are extremely grateful to all the participants and accept our call to us being here with us. And we, in this webinar, we like to talk about the sonoanatomy and ultrasound technology in diagnosis of pain. Our distinguished moderator, Dr. Siris Prasad Amartya, and speaker, Dr. Ninadini Shrestha, I would like to thanks to you also to the huge effort, and also our and also thanks to Nepal Association of the Study of the Pain and co-sponsor with Sonic Medical, and make it possible today's event. Thank you very much for your time.
Okay. Then today's webinar, it will take about 1.5 hours. The whole webinar will be performed by the moderator, Dr. Shirish, and the speaker, Dr. Ninadini. So here I will have a brief introduction about the moderator, Dr. Shirish. He is the assistant professor from the Panton Academy of Health Sciences and also consultant pain physician from Nepal Pain Care and Research Center, and also the visiting faculty in Taradia, the pain clinic. He has very extensive experiences, no matter in academy or the practices in pain management. So Dr. Shirish, please have an introduction about the speaker, Dr. Ninadini, and also deliver the opening speech.
Thank you, Mandy, for a wonderful introduction. Today, we Sonic, me and Ninadini, as well as the whole Association of Pain of Nepal, would like to conduct a seminar, which is very important topic, and it is based upon the ultrasound, the intervention, the sonoanatomy, for the introduction of and the diagnosis of pain. And as we all know, shoulder pain is one of the most common problem in the patient that are visiting the pain clinic. And we all know that though the history taking and clinical examination is the most important part in the diagnosis for any pain and management, with the development of the medical science, especially the technology with us, nowadays in pain clinic, most of the pain physicians are using the ultrasound for better diagnosis and treatment. And today we'll be trying to share a small light in this vast topic regarding the ultrasound image and the intervention. And we are very lucky to be having Dr. Ninadini Shrestha, who is an inspiration in Nepal in the field of pain management. She inspired me as well as many pain physicians in Nepal to pursue the career of pain. She is a very she's an associate professor in the Department of Anesthesiology in TUTH, as well as she's also general secretary in the Nepal Association for Study of Pain. And she is very much academically and clinically oriented person. And we are lucky to have Ninadini with us to be delivering today's lecture. Okay, pass on to Ninadini for the starting of today's webinar. Thank you.
So Dr. Ninandini, please share your screen.
Okay, namaste and good morning, everybody. It gives me great pleasure to host this webinar as a speaker today. Before starting, I'd like to express my sincere gratitude to Visonic, Ms. Mandy Chang, Mr. Nagendra Shrestha, NS Biomedical for their encouragement and technical support. I'd also like to express my gratitude to our moderator, Dr. Suresh Prasad Amartya, for his kind words. And thank you for your time from his very busy schedule. I'd also like to thank Professor Dr. Anil Shrestha, who is the head of the department and president of Nepal Association for the Study of Pain. It was his initiative to, he approached me for this webinar as a speaker. So without much delay, we'll delve into the topic. So today's topic is sonoanatomy and ultrasound guided interventions in shoulder pain with live demonstration. Today, we'll be discussing some normal ultrasound appearance of the shoulder joint and its structures with a live demonstration first, following which we'll have a discussion on some common ultrasound guided shoulder interventions. To make the session a little bit oriented to clinical practice, we'll have a case scenario discussion, following which we'll have question and answer session. So starting with the basics of shoulder ultrasound. Many countries and many associations have different preference for position of the patient for shoulder ultrasound. But the guidelines of many societies and many countries still strongly recommend examining the position, examining the patient for shoulder ultrasound in the sitting position. The reason being that if the patient is seated on a revolving tool, we can easily access the anterior, the lateral, as well as the posterior aspect of the shoulder. In the same time, we can compare it to the contralateral side. The probe that we use is a superficial high frequency linear array probe, like you can see in the slide. And the exam setting preferentially can be a musculoskeletal setting or can be another setting, whichever suits you, which has a better musculoskeletal view. Sometimes I often use thyroid setting also for the MSK setting or for the musculoskeletal ultrasound of the shoulder joint. Regarding sonography of the shoulder joint, as Dr. Suresh rightly mentioned, it is a very complex structure and it is a very common problem, second only to low back pain. It is a complex structure with lot the ligaments, the bursa, the bone, the labrum, and the nerve. And the sonography of shoulder joint is important not only for static evaluation, but also for dynamic evaluation. So today I have divided the sonography of the shoulder joint into three aspects. The anterior aspect, I'll be demonstrating the long head of the biceps tendon, the subscapularis muscle and tendon, the acromioclavicular joint. In the lateral aspect, we will be demonstrating the supraspinatus tendon, infraspinatus tendon, the subacromial subdeltoid bursa, and the rotator cuff interval. In the posterior aspect, we will be demonstrating the supraspinatus muscle belly, the infraspinatus muscle belly, and teres minor muscle and tendon, the posterior joint recess, and the suprascapular nerve. So now we'll start with the live demonstration. So now we're going to demonstrate the ultrasound scanning of the shoulder joint. From anterior aspect of the shoulder joint, we will be evaluating first the long head of biceps tendon, the subscapularis muscle and tendon, and the acromioclavicular joint. We identify the long head of biceps tendon on the transverse view by placing the ultrasound probe along the anterior sac of the humerus. And as we scan upwards, we see the bicipital groove, which is formed medially by the lesser tuberosity and formed laterally by the greater tuberosity. The long head of biceps tendon is seen as an echogenic oval structure, which is very prone to anisotrope. So as I rock my probe anteriorly and posteriorly, the appearance of the long head of biceps tendon changes. So once I scan the long head of biceps, I go all the way above
from the rotator cuff interval superiorly, and then I scan all the way down till there is appearance of the pectoralis major tendon. So that's where I stop scanning the long head of biceps tendon. So so on the short axis of scanning of the long head of biceps tendon, what I see is that the long head of biceps tendon is in the bicipital groove. It is neither dislocated nor is it subluxated. Also, what we would like to look for is possibility of a hypoechoic halo around the tendon. So if there is a hypoechoic halo around the tendon, then we know that there is a effusion within the biceps tendon sheath. So, but there is no halo, so there is no effusion. So once we see the biceps tendon in the short axis, what I do is carefully turn my probe 90 degrees to see the biceps tendon in the long axis. So once I see the biceps tendon in the long axis, I scan it all the way up. I trace it all the way up. And then I trace it all the way down till it's myotendinous junction. That's myotendinous junction of the biceps tendon. Again, scanning it all the way up. Okay, so after looking at the long head of biceps tendon, now we can have a look at the subscapularis muscle and tendon. After looking at the long head of biceps tendon, now we'll be scanning the subscapularis muscle and tendon. We start scanning from the same place where we had looked at the bicipital groove. Now I would like to ask my volunteer to externally rotate his arm as much as possible. So what this maneuver does, it brings out the subscapularis muscle and tendon from below the coracoid process. So medially when I scan, I have to look for my bony landmark. So this is the coracoid process. And I scan laterally and I see that the whole of the subscapularis muscle, which is changing, this is the myotendinous junction, and then it goes over and then gets inserted to the lesser tuberosity. So while I scan the subscapularis tendon, I have to scan it whole superiorly to see the whole extension of the tendon, inferiorly, as well as anteriorly and posteriorly. So this was the long axis of the subscapularis muscle and tendon. So after looking at the subscapularis muscle and tendon, now I turn my probe 90 degrees to look at the short axis view of the subscapularis muscle. So this is the short axis view of the subscapularis muscle and tendon. Here we can see that it has a multiplanar appearance with a lot of hypoechoic and hyperechoic bands in between. So we should not be confusing this with any tendinosis or interstitial tear. So this is how a subscapularis muscle appears in a short axis. So again, I have to see the whole section of the muscle and tendon. So I scan it medially, laterally, superiorly, and inferiorly to see how, if there is any pathology in the subscapularis muscle or tendon. So now we're going to look at the acromioclavicular joint. It is a very superficial structure, and we can see it by either palpating the very superficial AC joint and putting our probe over it, or we can just scan the bicipital groove again. And from the bicipital groove, we just scan up, and we reach the acromioclavicular joint. Here, the acromioclavicular joint is formed medially by the clavicle and laterally by the acromion process. So another method is we can always palpate the clavicle, and the most prominent bony structure is the acromion process. And we just drop our probe over it, and we can see the acromioclavicular joint. Again, Medially, it's the cortex, the hyperechoic cortex of the clavicle, which is causing an acoustic shadow. And laterally, it is the acromion process. We can scan the whole of the AC joint superiorly and anteriorly and posteriorly. And superiorly, it is formed. There's a superior acromioclavicular ligament, which we can see. And the hyperechoic structure deep inside the joint is the fibrocartilage structure inside the joint. So we have to look for any osteophytes or any irregularity in the joint space, or if we can also look at by dynamic scanning the laxity in the joint or the dislocation of the joint. So now we're going to look at the lateral aspect of the shoulder joint. Here we are going to scan the supraspinatus muscle and tendon, the infraspinatus muscle and tendon, the subacromial subdeltoid bursa, and the rotator cuff interval. So first we'll have a look at the supraspinatus muscle and tendon. I place my probe in the long axis view of the supraspinatus muscle. So what this maneuver does is it brings out the supraspinatus muscle from under the...
I just like to highlight that the position of the patient for evaluation of the supraspinatus muscle, it is a modified crash position in which the patient reaches his hand for the back pocket and the elbow is flexed and the shoulder is extended.
Acromion complex. So it appears as a bird's beak appearance. Almost all rotator cuff muscles have a bird beak appearance. This is on the long axis. I scan the whole of the length of the supraspinatus muscle. So to identify the muscle, I think it's always best for beginners to count our layers. So let's count our layers in the scan. The most hyperechoic structure superficially is the skin and the subcutaneous tissue, below which we see a dark hypoechoic deltoid muscle, which has fibrillar bands, below which we see a hyperechoic line again, which is a subacromial subdeltoid bursa, below which there is a hyperechoic supraspinatus muscle, and below which there is a hyperechoic cortex of the head of the humerus, below which there is an acoustic shadow. So to know whether we are completely aligned our probe with the long fibers of the supraspinatus muscle, we can look at the fibers of the deltoid muscle. And if the myofibrillar complex is parallel, then we know that we are on the long axis. Another way by which we can know whether we are in the complete long axis or not alignment is by looking at the long axis of the long-headed biceps tendon. Now we are going to have a look at the lateral aspect of the shoulder joint. Here we are going to look at the supraspinatus muscle and tendon, the infraspinatus tendon, the subacromial subdeltoid bursa, and the rotator cuff interval. So first we'll ask our volunteer to flex his elbow, extend his shoulder, and put his hands in his back pocket. So what this maneuver does is it brings out the supraspinatus muscle and tendon from below the acromial edge. After positioning the patient, we'll put our probe along the long fibers of the supraspinatus muscle. So the supraspinatus muscle, along the long fibers, it has this bird's beak appearance. Like almost all the rotator cuff muscles on long axis has this bird's beak appearance. So as a beginner, to identify the muscle, it's always a good idea to count your layers in the screen. So let's count our layers. On top, the hyperechoic line is the skin and the subcutaneous tissue. After that, there is this hypoechoic muscle layer, which is the deltoid muscle. Inside the deltoid muscle, we can see parallel muscle fibers. Just below the deltoid muscle, there is a white line, a hyperechoic line, which is the subacromial subdeltoid bursa. It is actually a potential space, which is now completely collapsed, which in case of effusion, we can see a collection over there. It's hyperechoic because of its fat content. Just below this subacromial subdeltoid bursa, we can see the supraspinatus muscle, the long fibers. We can see the fibrillar pattern of the muscle fibers. Below the supraspinatus muscle there is a hypoechoic cartilage, which is the articular cartilage, and below the articular cartilage, the hyaline cartilage, there is this white line again, which is the head of the humerus cortex. So after counting our layers, how do we know that we are actually, my probe is aligned along the long fibers of the supraspinatus? So we can look at the deltoid muscle and look at this parallel muscle fiber echogenic lines. If those lines are parallel to each other and to the supraspinatus muscle, we know that we are parallel to the long fibers of the supraspinatus muscle. Another way of doing this is we can also look at the biceps tendon long fibers, as you can see over here inside the supraspinatus muscle. So if we see the long fibers in the long axis of the biceps tendon, that also tells us that our probe is aligned parallelly with the long fibers of the supraspinatus muscles. After counting our layers, we have to scan the supraspinatus muscle and tendon in the whole of it. So we scan it superiorly to inferiorly, anteriorly to posteriorly, all the way. And as we scan the supraspinatus muscle posteriorly, so here we can see that we can see the infraspinatus tendon coming into the picture, and both of them, the supraspinatus as well as the infraspinatus, it goes on and inserts to the greater tuberosity. So scanning supraspinatus posteriorly might be a little confusing to identify the infraspinatus tendon. So there's an easy way to doing it. We look at our greater trochanter. So the greater trochanter is more, it has this configuration of this little...
I'm sorry, I meant the greater tuberosity.
Sharp edge anteriorly, while where we scan posteriorly, it becomes rounded, as we can see in the scan. So when we are anteriorly and the greater trochanter is pointed like that, we know that we are looking at the supraspinatus tendon. As we scan posteriorly, when the greater trochanter becomes rounded, we know that we're looking at the infraspinatus tendon fibers. You can scan it all the way posteriorly to see its insertion and see whether the tendons are normal or pathological. So one more thing to note is that when we are scanning the supraspinatus muscles along its long axis and we go all the way up to see its insertion to the greater tuberosity, sometimes we may come across some anisotropy like this. So if we see an anisotropy like this, we should not jump into conclusion of a pathology. We should always rock our probe to trace whether we can see a normal fibrillar pattern of the supraspinatus tendon. As long as we see this normal fibrillar pattern, this is a normal tendon. This anisotropy could be because of the curving of the fibers of the supraspinatus tendon. So still, when we look at the insertion of the tendon to the greater tuberosity, we still see some thin hypoechoic line, that is the articular cartilage above which the fibers of the supraspinatus tendon go and insert to the greater tuberosity. So after scanning the supraspinatus muscle along the long axis, I turn my probe 90 degrees gradually and evaluate the rotator cuff interval. So this rotator cuff interval, posteriorly, all these fibers that we see is the supraspinatus tendon in the short axis. As I scan more posteriorly, we can see the infraspinatus tendon coming into the picture. Okay, again, anteriorly the rotator cuff interval. And as I scan posteriorly, we see the supraspinatus muscle fiber and tendon. And as I go more posteriorly, the infraspinatus tendon coming into the picture. So again, in a short axis, it's easier to differentiate whether we are looking at the supraspinatus muscle fibers or we are looking at the infraspinatus muscle fibers. So how do we do that? So we look at the greater tuberosity again. So greater tuberosity have facets upon configuration. Anteriorly, the facets are more flattened. This is where the supraspinatus tendon attaches. Posteriorly, it has a more oblique orientation, and that is where the infraspinatus tendon attach. And even more posteriorly, it has a very vertical facet. That is where the teres minor tendon comes and attaches. Okay, so this is where the teres minor tendon comes and attaches. Okay. So now as we go anteriorly, just anterior to the supraspinatus tendon is a rotator cuff interval. So this is the rotator cuff interval. The rotator cuff interval is actually a space superiorly of which is the, as we just saw, supraspinatus muscle fibers and tendons. Inferiorly is the cephalic fibers of the subscapularis muscle. So as we go more anteriorly, from the posterior, we're looking at the supraspinatus fibers, and as we go anteriorly, now we'll be able to see the rotator cuff interval. Superiorly to the rotator cuff interval are the supraspinatus tendon. When I go even more posteriorly, that's the infraspinatus tendon. And as we go anteriorly, that's the rotator cuff interval, the biceps tendon. Anterior to the biceps tendon are the cephalic fibers of the subscapularis muscle. So this is the rotator cuff interval. Rotator cuff interval is a space where superiorly it is bounded by the supraspinatus tendon, inferiorly by the cephalic fibers of the subscapularis muscle, and the floor is made by the head of the humerus. So looking at the rotator cuff is important. It consists of three structures. The hyperechoic short axis long head of biceps tendon. Superior to the tendon is the coracohumeral ligament. Inferior to the tendon is the superior glenohumeral ligament. It is one of the dynamic stabilizers of the shoulder joint, and it is very commonly involved during the pathology of adhesive capsulitis. So this ligaments around the biceps, it forms an inverted C-shaped structure to hold the biceps tendon in place, which is also known as the biceps pulley. Now we are going to look at the posterior aspect of the shoulder joint. Here we are going to look at the supraspinatus muscle belly, the infraspinatus muscle belly, the teres minor muscle belly and tendon, the posterior joint recess, and the suprascapular nerve at the suprasternal notch and the spinoglenoid notch. The bony landmarks that we need to remember is the spine of scapula. In thin individuals, we can easily palpate it. So this spine of scapula divides the shoulder, the rotator cuff muscle belly into the supraspinatus fossa and the infraspinatus fossa. The supraspinatus muscle arises from the supraspinatus fossa, and the infraspinatus muscle arises from the infraspinatus fossa. Now, beginning to scan, we can just scan along the spine of scapula, and we see that inferior to the spine of scapula, we can see the infraspinatus fossa and the infraspinatus muscle. The spine of scapula, above the spine of scapula, we can see the supraspinatus muscle fibers and tendons. So while we scan the supraspinatus muscle fibers and tendon, as we scan laterally, the lateral part of the supraspinatus muscle may be difficult to see because of the acromial complex shadow. Even along the long axis, when we are scanning the supraspinatus muscle fibers and tendon, we can see that this is along the long axis. We can see the nice myofibril patterns of the supraspinatus muscle. And as we go laterally, we can see there is a myotendinous junction. And as this is the tendon of the supraspinatus muscle, but we cannot see beyond the acromion complex. Now, we can, once I evaluate the supraspinatus belly, anteriorly, posteriorly, medially, and laterally, now we again go to the spine. Now, going inferiorly to the spine, the infraspinatal muscle belly on the short axis, we scan it like this, just below the spine of scapula, medial to lateral. Okay. So after identifying the infraspinatus muscle belly in the short axis, as we go laterally, we can see the teres minor coming into the picture. So below infraspinatus, there is a teres minor muscle. So after identifying the infraspinatus muscle on the short axis, we turn the probe 90 degrees to identify the long axis view of the infraspinatus muscle. As we can see again, the nice myofibrillar patterns, and we scan all the way laterally till we see it turning into the tendon. This is the myofibrillous junction of the infraspinatus muscle. This is the tendon, and it goes and inserts to the greater tuberosity. So below the infraspinatus is the teres minor muscle, which starts on the lateral part of the scapula. See my proposition, as I scan laterally, On the lateral part of the scapula, we can see the teres minor muscle, which again forms the tendon below the infraspinatus muscle, goes all the way and then inserts to the greater tuberosity. It's easier to view the teres minor muscle in the short axis. So again, scanning the infraspinatus muscle in the short axis. As I go laterally, so we can see the teres minor muscle arising from the infraspinatus fossa, changing into the tendon below the infraspinatus, and then going and inserting to the greater tuberosity. So now we shall try to trace the suprascapular nerve. The suprascapular nerve starts from the brachial plexus. It courses along the posterior triangle, and it enters the shoulder girdle via the suprascapular notch. It gives a branch to the supraspinatus muscle. Then it winds around the spinoglenoid notch and gives a branch to the infraspinatus muscle to supply the motor supply. So now one way to identify the suprascapular nerve along the spinal scapula is we put our probe along the spinal scapula and we just slide our probe or walk our probe anteriorly. So see, this is the spine of scapula. And as we slide our probe anteriorly, we see that there is a defect in the superior cortex of the scapula. So this is the suprascapular notch. In this notch, if we look carefully, we see a pulsating structure. So if you observe carefully, you can see it even in this gray scale. So that pulsating structure is the suprascapular artery. The nerve is just next to the suprascapular artery. Okay, so nerve is just next to the suprascapular artery, and you may or may not be able to see this signal on color Doppler. It doesn't matter because even in a grayscale, you can see the pulsation of the artery. Now, as the suprascapular nerve gives a branch to the supraspinatus after crossing through the suprascapular notch, now we have to look for the spinoglenoid notch. So it's easy to identify the spinoglenoid notch. We again look for the posterior glenohumeral joint. So when we find the posterior glenohumeral joint, we just scan little bit medially. Okay. So we identify the joint, and when we gently slide the probe medially, right medial to the posterior glenohumeral joint is a valley-like structure, as you can see in the picture. Right. So this is the spinoglenoid notch. So the suprascapular nerve, it nestles in this notch. Again, you have to look for the pulsating suprascapular artery. So even in a grayscale, you are able to see that pulsating artery. So the suprascapular nerve will lie just next to the suprascapular artery. Again, in a color Doppler or a power Doppler, you may or you may not be able to visualize the artery. And that's all right. So sometimes what happens is small cyst may appear in the labrum, in the posterior superior labrum, maybe because of trauma or degeneration. A paralabral cyst may form, which can course medially and then comes to the spinoglenoid notch. And then it may compress the suprascapular nerve, which may cause atrophy of the infraspinatus muscle. So this may be one of the important findings to see in a patient who has weakness or atrophy of the infraspinatus muscle. Or Doppler, you may or you may not be able to visualize the artery, and that's all right.
I'm sorry, I just wanted to emphasize on how to scan the posterior glenohumeral joint. So how we scan the posterior glenohumeral joint is we just put our probe over the posterior axillary fold, and we just scan, as we saw that we scan the infraspinatus muscle fibers, we just scan on the long axis of the infraspinatus muscle. So the glenohumeral joint.
Yeah, this infraspinatus joint. So
this is how the posterior glenohumeral joint recess looks like. This is the head of the humerus. I just can see the hyperechoic line. And this is the glenoid cavity. And this gray little hypoechoic structure is the labrum. So this labrum holds the head of the humerus. This joint is very important in the perspective of pain management, because treatment of the posterior glenohumeral joint has shown to provide better analgesia in case of adhesive capsulitis. It's not only static imaging. By dynamic imaging, we can see whether there is even minimal effusion in the posterior glenohumeral joint can be seen by dynamic scanning, in which we can just ask our patient to internally or externally rotate their hand, in which even this head of the humerus will move and even minimal amount of fluid can be seen at the posterior joint recess.
Find the posterior glenohumeral joint. So now we shall try to trace the suprascapular nerve. The suprascapular nerve starts from the brachial plexus. Okay. Form which can course medially and then comes to the spinoglenoid notch.
Okay, so I think we've covered mostly all of the different aspects of scanning the ultrasound joint. So now we'll proceed with the presentation. If you have any questions, you can please type your questions in the Q&A session. So after demonstrating the normal ultrasound picture of the shoulder structures, I'd like to just show how the common shoulder pathologies look like. So here we can see the long head of the biceps tendon in the short axis view. This is the bicipital groove. This gray echogenic structure, oval structure is the long head of biceps tendon. So I was talking about this echogenic hypoechoic halo. So if this hypoechoic halo is present around the tendon, then it tells us that there is some collection, some effusion around the tendon in the bicipital tendon sheath. So this is the short axis view, and this is the long axis view. In the long axis view, this is where the biceps tendon was supposed to be, but there is completely anechoic and hypoechoic areas, which tells us that either there is severe tendinitis of the biceps tendon, or there can be a complete rupture of the biceps tendon. So the inflammation, if you put a collar Doppler across the short axis, if there is flaring of the collar like this, which shows there is marked inflammation around the tendon, so we make a diagnosis of bicipital tendinitis. So another common structure that we identify in ultrasound is retrocuff pathologies. So here we're looking at the supraspinatus in a short axis view, where we can see there is a full thickness tear of the supraspinatus muscle. This is another long axis view where we can see partial tear of the supraspinatus muscle. This is the long axis view of the subscapularis muscle, where we can see there is hypoechoic areas inside the muscular fibers, confirming the diagnosis of the subscapularis tendon there. So this is another image showing the effusion inside the subacromial subdeltoid bursa. Remember that we counted the layers from top: skin, subcutaneous tissue, the deltoid muscle, and then the white hyperechoic line now is a two-layered line with a hypoechoic fluid collection inside it. There's also thickening of the synovium. If you can see, it is almost a 0.5 centimeter thick in both the sides, and there is marked effusion inside the bursa, below which is the supraspinatus tendon and the greater tuberosity. This is another picture, again showing the same pathology, where I just wanted to highlight about the type of fluid that is inside the subacromial subdeltoid bursa. It is thick and it is turbid, and you can see a lot of white structures floating inside the effusion, which tells us that it is a bad inflammatory soup. Another picture showing the acromioclavicular joint arthritis. This is the clavicular end, this is the acromial end. You can see that there's osteophytes and the joint space is reduced and distorted. So confirming the diagnosis of acromioclavicular joint arthritis. This is a picture showing the posterior glenohumeral joint. This is the humerus, and this is the glenoid cavity. We can see that there's marked reduction in the joint space with irregularity in the bony lining, as well as there is a collection which is inside the capsule, but in the posterior glenohumeral joint. So this confirms the diagnosis of the glenohumeral joint arthritis. So, so we've looked at the normal sonoanatomy, and now we've seen how pathology of the shoulder joints look in the ultrasound. So now we discuss about the ultrasound-guided shoulder interventions. Before talking about shoulder interventions, what I would like to say is that before planning any ultrasound scanning or intervention, it's very, very important that we take proper clinical history from our patients and do proper clinical examination. Shoulder joint has a lot of pain generators. So it's not possible to scan all the structures all the time in your busy clinical practice, as well as if you see even anything small pathology, you should not jump into doing shoulder interventions. We determine the diagnosis, pain diagnosis, based on the patient's clinical history and patient's clinical examination. So the clinical examination helps us in a big way to narrow down our differential diagnosis and then plan our intervention accordingly. So if after clinical examination, if you suspect any pathology and if you do your ultrasound scan and if you see some finding and if you're not sure, it's always better to send for some clinical investigation as well as do some imaging study to confirm your diagnosis before planning on your interventions. So now we'll start with the ultrasound-guided shoulder interventions. First, we'll be discussing all these interventions one by one. So starting on discussing the intervention on the long head of biceps tendon. Again, recapitulating the anatomy. This is the cadaveric model that's showing the biceps long head tendon. So you see this is a subscapularis muscle on the medial side of the tendon. The subscapularis muscle tendon, it merges with the transverse humeral ligament. So biceps tendon has a very close association with rotator cuff pathology, especially subscapularis muscle. So this is how the anatomical correlation is there. This is another view from medial to lateral view of the long head of biceps tendon. This is the cross section of the long head of biceps tendon at the rotator cuff interval. So this is the subscapularis muscle anteriorly or medially, and this is the supraspinatus muscle. You see there is a, sorry. So you can clearly see that there is a gap here, the triangular gap between the muscles. That is where the rotator cuff interval is. So this biceps tendon forms the biceps pulley in this rotator cuff interval. And you can see that there is this coracohumeral ligament and the superior glenohumeral ligament forming the pulley, okay? So whenever we see biceps tendinitis or we suspect biceps tendinitis in ultrasound scanning, we should be very careful before jumping into that diagnosis and intervening there, because primary bicipital tendinitis is very, very rare. I think in my practice, I have not seen an isolated biceps tendinitis till date. But biceps tendon disease can be divided into tendinitis or tenosynovitis, but mostly it is associated with rotator cuff pathology. So you always have to rule out rotator cuff pathology before before making a diagnosis of primary bicipital tendinitis. So just to highlight the importance of ultrasound guidance in doing the therapeutic injection in biceps tendency. This was a study done by Jonel Pestkevez, just published in 2016. It was one of the first study which compared ultrasound guidance with fluoroscopy guidance for biceps tendinous injection. So they found that with ultrasound, the first pass success rate was 90.6% compared to 74% for fluoroscopy. And ultrasound guidance had a higher success rate, and it also helped visualize the abnormality before injection to make a better diagnosis. But there was no, but both the technique had similar pain relief and similar complication rate. Another study published in Scientific Reports, they associated bicipital peritendinous effusion with subacromial impingement. It was a dynamic ultrasound study where they showed how you can dynamically scan for subacromial impingement. So there is, in this study, they took a sample size of 337 shoulders, and any increase in age, subdeltoid bursitis, or thickness of supraspinatus tendon tear and shoulder stiffness was associated with the bicipital peritendinous effusion. So for injection of the biceps tendon, Many practitioners have different preference. My preference would be a needle of 25 gauge with 1.5-inch needle, a small needle, injected volume of maybe 2 to 4 ml. An approach can be in plane or out of plane both. And my target would be the synovial sheath. A successful injection should reveal the injected surrounding the tendon. And if the tendon swells up, the hypoechoic oval structure swells up during injection, then you should be very careful because you are injecting inside the tendon, not surrounding it. So at the level of the intertubercular groove, this is the biceps tendon. This is the greater tuberosity, lesser tuberosity. So this is the lateral part, and this is the medial part. Our needle will come from the lateral side to the medial side. We should always do a collar Doppler before putting our needle in to detect the ascending branch of the circumflex humeral artery, anterior circumflex humeral artery, which just lies in the same space. So your needle should avoid puncturing through that artery. And then you puncture the tendon sheath and inject around surrounding the tendon sheath. This is the in-plane approach. You can see in the inset the alignment of the needle and the probe. This is at the level of the intertubercular groove and the ultrasound-guided in-plane approach, where I target my tendon in the long axis from caudal to cephalic, and then inject just below the tendon sheath, not inside the tendon. So you have to be very careful that you're not injecting inside the tendon. So this is injecting the biceps tendon in the rotator cuff interval level. This is the short axis of the biceps tendon. This is the supraspinatus muscles. And we can put in our needle from posterior to anterior, and we can inject the tendon sheath after piercing the sheath. Okay, so now talking about the acromioclavicular joint. It is a synovial joint with its articular surface separated by a wedge-shaped fibrocartilaginous disc, which we saw as a hyperechoic structure in our scan. This is a coronal cross-section of the cadaveric acromioclavicular joint. What I would like you to focus on in these pictures is that this is the acromioclavicular joint. If you see carefully, just below the acromioclavicular joint is the subacromial subdeltoid bursa. And just below that bursa is your supraspinatus muscle. So if you put your needle in too deep, it's very easily that you can deposit your drug in the bursa or into the supraspinatus muscle. So you have to be careful that you don't introduce your needle too deep. This is one study which supports the accuracy of ultrasound guidance injection of the AC joint compared to the palpation guided landmark technique. So it's a very superficial joint. So many of a clinician, they practice this palpation guided acromioclavicular joint injection. But this study showed that acromioclavicular joint injection, on the palpation guided injection, there was only 40% success rate, whereas it has a very high success rate with the ultrasound. So for injection of the AC joint, mostly I inject AC joint if there is arthritis, if post-traumatic or osteoarthritis of the joint. The needle I use is again a small needle of 25 gauge with 1.5-inch needle. Injected volume will be very less. It's a very small joint. So you should not inject high volume, otherwise you'll rupture the capsule, which will cause even more severe pain to the patient than before. So I inject around 1 to 2 ml. My approach can be in plane or out of plane, depending on the patient's anatomy. Sometimes choosing only one way of injecting inside the AC joint can be difficult because of an osteophyte or because of the anatomical problems. And my target would be below the superior acromioclavicular ligament. So this is how we inject. My needle is coming in from the lateral to medial, and I puncture the superior clavicular acromial ligament and then deposit my drug inside the joint. This is on the in-plane ultrasound guided view, whereas this is a needle where you can see in an ultrasound guided out of plane view inside the joint. You can also do ultrasound guided in-plane approach on the sagittal section of the acromioclavicular joint. Sometimes in a very severe arthritic joint, this approach is very helpful. As you can see in the inset, you put your ultrasound probe like this and inject in an in-plane, but the sagittal section view. So this is the superior acromioclavicular ligament. You put your needle in like this from anterior to posterior and just inject below the ligament. Now talking about the subacromial and subdeltoid bursa, this is the cadaveric model where we can see that it is a potential space. It's a very big space and it covers a lot of area. But if it is normal, then it's completely collapsed. So there was one study where they compared ultrasound guided with blind subacromial soft deltoid bursa injection in adult with shoulder pain. This is a systematic review and meta-analysis. They found that ultrasound guided corticosteroid injections offer a significant greater clinical improvement over blind injection in the adult with shoulder pain. So again, for the procedure, I prefer the small needle because it's a very superficial structure, but many of the literature also mention using of a 22 gauge spinal needle, which is of 3.5 inch. The injected volume depends. It can actually be a range from 4 to 8 ml. So you have to see how much is the pathology there if you're injecting. And approach in plane, lateral to medial approach. I target the bursa outlined by the peribursal fat. If you are put your needle tip correctly inside the bursa, even a small volume of 0.5 ml of injected can be seen in your ultrasound screen spreading across the bursal plane. So that's the ultrasound guided in plane approach to the subdeltoid subacromial bursa, coming from lateral to medial side. So this is the short axis view of the supraspinatus tendon. You can also do the injections in the long axis view of the supraspinatus tendon. I prefer this technique because it's more comfortable for the patient as well as for the operator. And this is the bursa with thick synovium, and we inject inside the bursa. Talking about glenohumeral joint, the anterior aspect of a cadaver model of the glenohumeral joint. You can also inject through the anterior approach, and this is the posterior aspect of the glenohumeral joint, and which is the most commonly preferred approach to inject inside the glenohumeral joint. I prefer 22 gauge spinal needle, 3.5 inch for this procedure. My injected volume would range from 8 to 12 ml. An approach would be an in-plane lateral to medial approach. You can also do it in a different approach, but most of the practitioners have found in-plane to be more easy. And target would be between the free edge of the labrum and the cartilage of the neural head under the capsule. So correct placement of the injected in the posterior approach will result in spread of medication beneath the joint capsule. It should not spread into the infraspinatus muscle or outside the joint. So the indication for injecting in the posterior glenohumeral joint is either for the glenohumeral arthrosis or for the adhesive capsulitis, commonly known as frozen shoulder. There is this paper on scientific reports which talks about effectiveness of glenohumeral joint dilatation for treatment of frozen shoulder. It was a systematic review and meta-analysis. They analyzed and concluded that distension of the glenohumeral joint provides a long efficacy to all the reference treatment. Even a single dose of corticosteroid containing regimen, if you use it for distension of the glenohumeral joint through the ultrasound guided posterior approach, it is preferable for the management of frozen shoulder and has long-term pain relief. So now, just to show you how we can inject in the anterior glenohumeral joint, we have to ask our patient to externally rotate their arm as much as possible. That's when this maneuver leads to bringing out of the subscapularis muscle from the coracoid complex. So this is where the anterior glenohumeral joint lies. I prefer injecting in an in-plane technique from lateral to medial. You can also do an out-plane technique and inject into the anterior approach of the glenohumeral joint. So this is a picture showing the ultrasound guided in-plane approach from lateral to medial to the posterior glenohumeral joint. So you can either do it from lateral to medial or also from medial to lateral, depending on the patient's anatomy and your orientation. So this is the hyaline cartilage covering the head of the humerus. This is the labrum, this is the glenoid cavity. You should inject inside the capsule. So when you inject your drug, this capsule will be distended, but there should be no spillage of the drug into the muscle infraspinatus. You can also see the capsule distending over here above the hyaline cartilage, but it should not come out of the capsule. So now talking about the suprascapular nerve, this is the cadaveric model of the suprascapular nerve. So it comes out from the superior trunk, upper trunk, and then it travels in the suprascapular notch in the solar girdle, and then passes through the spinoglenoid notch. So the indication of suprascapular nerve block can be for pain relief of the adhesive capsulitis of frozen shoulder. There can be, you can treat suprascapular nerve block for suprascapular nerve compression neuropathy, or for palliation of acute pain or cancer pain, or post-operative pain, or for bursitis around the shoulder joint, or for adjunct treatment with aggressive physiotherapy also. We can combine it for pain relief. So if we want to inject suprascapular nerve at the brachial plexus level, so this is where we can inject. We can also inject the suprascapular nerve at the suprascapular notch, like we've already seen in the video. To inject this nerve, you can either do an in-plane technique from a medial to lateral, or you can do an out-of-plane technique. This is an ultrasound-guided in-plane approach to the suprascapular nerve at the infraspinatus fossa, the spinoglenoid notch. Again, we can inject it through the medial to lateral approach. So this is another study where they compare the effectiveness of suprascapular nerve block with physical therapy, placebo, and intra-articular injection in management of chronic shoulder pain. It's a meta-analysis of RCTs, where they've seen that suprascapular nerve block provided better relief after 12 weeks compared with physical therapy alone or compared with placebo injections. So they demonstrated that ultrasound was the most preference guidance tool to block the suprascapular nerve. And however, future studies advise to integrate physical therapy in order to improve the long-term effectiveness of this block. So now we'll be talking about the axillary nerve. This is the cadaveric model where we can see the axillary nerve at the posterior aspect of the shoulder. If the axillary nerve supplies sensory supply to the inferior and posterior part of the capsule of the glenohumeral joint. So if you want to control the pain in that area, you can do axillary nerve block. And this is an ultrasound guided in-plane approach to the axillary nerve at the quadrilateral space. This is how we do it. And this is the ultrasound guided in-plane approach of the axillary nerve at the head of the humeral neck level. You identify the lateral humeral circumflex artery, the posterior artery, and then you inject around it to inject the axillary nerve block. So another study, they compared the combination of the suprascapular and axillary nerve blocks to interscalene nerve block for analgesia in arthroscopic shoulder surgery. So this study showed that combining suprascapular and axillary nerve block provides very good analgesia, which is comparable with the interscalene block after arthroscopic shoulder surgery. So this can be a good information for us to incorporate into our chronic pain practice as well. So that was almost the end of my presentation. Now, I think we can carry on with the case scenario. If there is any question and answer for the live demonstration or for this presentation for the intervention, can we entertain it now?
Thank you for a wonderful presentation, Nina Dini. Till now, I haven't got any question, but like, I think people are so much interested in the presentation that they will be typing out the question.
I think we can firstly go with the case scenario, because normally we just finish all the webinar, then we will raise the questions. The audience will raise the questions.
Okay. So yeah. I'll proceed with the case scenario. This is just to give you a perspective, because we've been talking. I've been talking a long time, and you may have gotten lost in the way. So just to see, have a perspective on how ultrasound can help us with the diagnosis of pain and treatment. So this is just a case. So this case is of a 40-year-old diabetic car mechanic who presents to our pain management clinic with complaints of pain over the left shoulder area since past 7 months. Firstly, it started with mild pain, which had some response to pain medicine, but now pain is so severe that he has sleep disturbance with night pain and is not responding to drugs. So there's difficulty, and pain is caused by raising even the left arm. There's restricted mobility of the left shoulder, and patient is even unable to lie down on the left side. So on clinical examination, we see that the manual muscle testing has grade 3. There's a painful arm elevation. The Neer and the Hawkins test is positive, and the empty can test is also positive. So just for the audience, any differential diagnosis that comes to your mind, you can type in your answers in the Q&A session. Okay, so just to make it, if we are looking at the case scenario, so we also always have to consider for differential diagnosis. We cannot just jump into one conclusion. So we have to rule out trauma, we have to rule out infections, and we have to ask a good clinical history related to this patient. This patient is a diabetic, and we have to do a good clinical examination as well. So the painful arm elevation is, and the Neer and the Hawkins test, empty can test being positive, it is indicating that there is a problem with the rotator cuff muscles. But we also have to see if there is any joint problem, any arthritis problem. So we have to consider all the differential diagnoses. And then we have to send the investigation if we are suspecting any pathology, okay? So if needed, if you're thinking of an infection, you have to send a blood investigation, you have to do an imaging study, you can probably do an X-ray and an ultrasound, and then make your diagnosis. So X-ray was done in this patient. So you see any finding in the X-ray? The blood investigations came out normal with a slightly raised blood sugar level, but in this X-ray, there was some finding. So I'll just go ahead with the case. In this X-ray, you can see that there is the reduced interval, okay? So the interval is reduced between the head of the humerus and the acromion process. So this tells us that there is some rotator cuff pathology, because if the gap is increased, then we know that there is a dislocation of the shoulder joint, and if the gap is decreased, then we know that there is a rotator cuff pathology. Then comes to our part for diagnosis, we can always do a musculoskeletal ultrasound finding. So in this patient, what we found was the subacromial subdeltoid bursa. There was slight collection over there. There was a small hypoechoic area in the supraspinatus muscle. The MRI of the shoulder joint also confirmed our ultrasound diagnosis. There was this in the bursal surface of the supraspinatus. This is the subacromial subdeltoid bursa. Along the bursal surface, there was partial tear of the supraspinatus tendon. And even in the insertion area, the articular surface, there was some echogenicity showing that there was inflammation along the tendon of the supraspinatus muscle. So till now, is there any question regarding this case scenario?
Dr. Suresh, you can check in the Q&A box and then raise the question to Dr. Ninadini, then she will answer.
Till now, regarding this case scenario, there is no question, Nina, so please proceed.
Okay, so that was a case of supraspinatus partial tear causing a reactive subacromial subdeltoid bursitis and causing shoulder pain. Okay, so I think I finished my case scenario, and now we are in the Q&A session.
Okay, Nina, thank you for the wonderful presentation, both sonoanatomy as well as live demonstration. There are a few interesting questions. Hello?
Can my voice be heard?
Yes, it can be heard.
Yeah, I'm Dr. Begin.
Okay, namaste, Dr. Begin.
I have a question to Dr. Ninadini. Okay, this type of case scenario is common in our pain clinic. Most of the times, we get the patients who have been going to the pain physicians, and they come to our pain clinic at the last step with the chronic pain more than 6 months, 12 months, maybe 1 or 2 years. And on the clinical examination also, most of the clinical signs overlap, maybe because they have multiple pathologies. And when we perform the ultrasound, we see different findings like arthritis of shoulder joints, subarachnoid bursitis, supraspinatus, tears. Multiple findings are there. So can you tell me how we go ahead when we find that in the clinical setting also there is a multiple pathology which is also confirmed in the ultrasound? So will we do multiple intervention at a similar setting, or we would like to do one at a time?
Should I answer that
Yes.
question?
Yes, yes, Nina, please.
Okay, thank you, Dr. Begin, for the question. It's just that muscle partial tears is very common finding in ultrasound scanning. Even in an asymptomatic patient, around 60% of the patient may show rotator cuff partial tears. So we don't treat whatever finding we see in ultrasound. It's very important for us to correlate the finding with the clinical history and clinical examination. So if the pain that is causing the limitation of the activity or causing the problem to the patient is correlating with the ultrasound finding, then only we treat that partial tear. It's said in the medical literature, you can easily see that even for patients with age above 65 years, finding partial tear of rotator cuff muscle is very, very common. So we only treat the partial tears if we confirm the diagnosis that is the pain generator, which is causing the pain and limiting the joint movement and causing distress to the patient.
And what about the multiple pathologies? Like you have subarachnoid bursitis, on top of that frozen shoulder. So we should do the multiple pain intervention at a similar setting, or would you like to do one setting at a time?
Okay, so thank you for that interesting question, because it's very important. What I would like to say is that we have to find the pain generator. So we should always think in terms of a pain diagnosis. So what is the primary pathology that has led to for the secondary pathologies? Usually what happens is rotator cuff tears. Firstly, there is partial tear with mild pain, and patients ignore that pain with analgesic and the pain subsides. And after years of not getting treated completely, the partial tear itself turns into complete tear or is increased in size. And then along with the tear, they also have a reactive bursitis. They also have acromioclavicular joint arthritis. So the frozen shoulder, even the glenohumeral joint arthritis develop later on because of the abnormal movement of the shoulder, scapula, the glenohumeral joint. So it's that the pathology develops over years. And then when we see the patient at the, let's say at the later years, they have a lot of pathology that we can identify in ultrasound. Now that picture can be a little confusing because you don't know whether you want to inject the bicep tendon first or the bursa first or the glenohumeral joint first. So you have to again take a detailed clinical history and see, so what is your primary pathology that could have led to the secondary findings. So I usually prefer injecting first, either if I can find the primary pathology, if I can think of a primary pathology, I inject that first. Or if I don't know what the primary pathology is, I treat the condition that is causing the most distress to the patient. So what is causing most distress to the patient? Whether it's internal rotation or the external rotation, what is it that causes maximum pain? So I decide on that value what I inject first. And I don't do usually multiple intervention on the same setting. I counsel my patient and I usually divide the intervention over 2 weeks each over time, and then inject slowly, because sometimes injecting into one primary structure can revert the pathology and treat other conditions as well. And you may not need to inject the other structures later on. So I hope I answered your question, Dr. Begin.
Yeah, thank you, because it is the most confusing part when we get the multiple pathologies. Should we treat all in the one setting, or we divide into the
Yes, maybe Dr. Sri should also add on to his experience on this question.
Thank you, Nina, and thank you, Dr. Begin, for the wonderful question. Like Nina Dini has rightfully said, we have to first identify the pain generator, and though there can be multiple pathology in the ultrasound or MRI, which usually in pain clinic patient comes with MRI. With telling all the conditions that you have mentioned, Dr. Begin. And in that condition, as my teacher has always stresses, Dr. Gautam Das, he says that first, don't treat the MRI or the USG, treat the clinical pathology that is bothering the patient the most. And we usually go, my clinical practice, I usually try to decrease the pain in the first setting, like if the common cause is pain, I try to divide the scenario like Nina Dini into 2 or 3 settings, and slowly initially take care of pain by giving either suprascapular block or intra-articular steroid block. And in my clinical practice, I have found the suprascapular nerve block can be an excellent minimally invasive procedure to relieve pain. And once the pain is relieved, then I observe the patient in 2-3 weeks, and then again counsel the patient that it is not a one-time or one-shot treatment, and gradually plan the procedure as the clinical scenario changes. But like first, patient has come to us for decreasing the pain. I try to decrease the pain either with oral medicine or suprascapular nerve block, and then see what are the remaining pathologies gradually then.
It seems that the image from Dr. Shrish is not very good.
There is some internet problem.
I think treating up increase the pain it's required. Can you see it? Am I audible?
No, I think now it's okay.
Okay. So, Dr. Begin, like pain, it's not a single shot treatment. We gradually, along with the clinical presentation and problem of the patient, we categorize the like in triads, slowly treat the what is bothering the most, and gradually go back and treat the least bothered part of the patient. Thank you, Dr.
Thank you.
Have I answered you, sir?
Yes. Because it's the most common problem that we face in the pain clinic. And I have another question also. So for the intervention we usually use corticosteroid and plus local anesthetic mixer. And nowadays there is a concept of 5% dextrose, 10% dextrose, and even PRP. That is slowly evolving. So is there any demarcation there? Is there any guidelines to suggest whether we should directly go for the 5% dextrose in the first setting, or we should try with the traditional corticosteroid or PRP?
Dr. Nina?
Can I take that question? Okay.
Okay.
Thank you so much for the question, Dr. B. So regenerative medicine or prolotherapy treatments, they're basically still new. And I don't think there is very strong papers or evidence or randomized control trials that have formulated into guidelines. But there are a lot of papers coming out about it, and there are a lot of level 3 evidence at least to start using them in our clinical practice. I personally have a very good experience with using dextrose prolotherapy as well as PRP. So it's not what determines which first. It's basically what is the pathology that you are dealing with. So PRP, platelet-rich plasma, which has a high concentration of platelet and growth factors, it is mostly useful if you inject it inside the joints.
Yeah.
So I would inject it inside the AC joint or glenohumeral joint. Dextrose is a very strong irritant, chemical irritant, but it's very good drug, as well as it's very cheap. So talking about treating 4 patients with this pathology in our setup. So PRP is a little bit expensive because of its processing and its kits. So depending on the pathology, if it is joint degeneration, joint osteoarthritis, I would prefer using PRP. If I'm injecting inside the tendons, I would prefer injecting platelet-poor plasma, PPP, or dextrose injection. To inject inside muscle tears, partial tears, I would prefer injecting PRP. So it depends on what you are treating first. But using dextrose, if the patient is not affording PRP or PPPs or bone marrow concentrates, is a great idea for a country like ours, where lots of poor patients don't have access to high medical care. So dextrose prolotherapy, if used judiciously, can give you a result which is as good as PRP. It's just that you might have to repeat the injections sometimes. But
so we can inject the dextrose into the joint if we suspect of some frozen shoulder.
Yes, of course.
Yeah. So one question may be arise that if we using the dextrose, our traditional teaching is that dextrose is good medium for the bacterial growth. So if we are directly injecting the dextrose, should we take extra precaution or some antibiotic prophylaxis?
Okay, I'll answer
that. Okay, Nina, we both will answer that.
So the dextrose that we use is a medical pharmaceutical dextrose. So it is already sterile. We always use our sterile precaution in all our procedures. Especially if you are injecting inside the joint, you have to take special precautions because we do not want to infect our joints. Having said that, dextrose is also a very good chemical in the sense that it is inside. It is just dextrose. It is glucose basically, which is also there inside our body, and it is water soluble. The most important thing about injecting dextrose is it's water soluble. So as soon as we inject dextrose, it doesn't stay inside a cavity and stay there for a long time. It is water soluble, it gets disseminated, and it spreads very easily to the tissues. So I don't think if we take sterile precaution for interventions, injecting dextrose would have any risk of causing infections.
So, yeah, so we don't have to use the antibiotic prophylaxis.
No, I don't think
no.
so. I don't.
Yes.
Dr. Begin, I usually, in my clinical practice, like as we are injecting in joint, as Nina Dini has said, all aseptic precaution has to be taken whether we are injecting anything, PRP, steroid, or dextrose. And it is just a myth that dextrose prolotherapy or anything with dextrose will cause more infection in patient, and we are more worried about the infection. But in my clinical practice, what I usually do is, if the patient is diabetic and if the diabetes is slightly in a higher side, I usually go for a single set second generation antibiotic prophylaxis. But normally, if the blood sugar is normal, or if the patient is not diabetic, we usually don't go for the antibiotic prophylaxis.
Also,
yeah, okay.
The one more thing to add on that is it's what we are trying to do with the prolotherapy is we're injecting irritant inside the diseased tissue to cause local inflammation with the hope that the body will now heal the tissue with a good immune response. So giving antibiotics can also alter that response. So using antibiotic blindly in a blanket manner is not recommended. Like Dr. Siri said, if there is a risk of infection with a diabetic patient with high blood sugar, you can choose to cover your procedure with an antibiotic, but routine use of antibiotic for any prolotherapy, even PRP or dextrose, is not recommended.
Okay. There is one very good question from our new member in Pain Society, Dr. Joy Prakash. He has said that what is the concentration of dextrose that we usually use for the procedure of prolotherapy? Okay, Nina.
Okay, thank you, Dr. Joy Prakash, and nice to hear from you actually. So I would like to answer that question. I use dextrose rampantly in my practice. So there's a different concentration of dextrose I use for different pathological conditions. So let's say if I'm doing a nerve hydrodissection for peripheral nerve entrapment like a carpal tunnel syndrome, I would use 5% dextrose only. Whereas if I'm injecting dextrose inside the tendons like a biceps tendinitis, I'd go for a slightly higher concentration, 10 to 12%. But no, if I have to inject it inside articular space, provided I have no other options, then I prefer a higher concentration than that. I'd probably even go to 25%, depending on the patient's condition, because some patients who have very refractory pain to other treatments, I prefer using high concentration dextrose in those patients. So I hope I have answered Dr. Jayaprakash's question. Dr. Jayapakash, if you are here, you can join.
Can I go to other questions? One person has said that, can we inject steroid in the muscle?
Oh.
Nina, can we inject steroid in the muscle?
Well, I think some people do inject steroids in the muscles if they are planning on building up the muscles.
But not for the treatment of pain.
But not for the treatment of pain. So they inject anabolic steroids for, making bulky muscles or going for Mr. Handsome competition, I guess. But generally, as medical treatment for chronic pain conditions, steroid is not recommended anymore to be injected inside the muscles. It can be injected inside the joints, the arthritic, the inflamed joints, or inside the inflamed bursa. If there is huge effusion with bursitis, I would prefer injecting steroids first inside the bursitis to decrease the inflammation. And in the second stage, after probably 3 to 4 weeks of injecting steroids, I can plan for other treatment therapy like prolotherapy or other stuff. So no, my answer is you cannot inject steroids inside the muscles. What do you think?
Okay. No, it is absolutely, it's a red zone area. We are not supposed to inject steroid in the muscle, at least for a pain management perspective. Another question is for the adhesive capsulitis, as it is most common clinical condition that we visit in, for the patient visit in the pain clinic. One person has asked whether the anterior or posterior glenohumeral joint injection is more useful, and is hydrodilatation useful in adhesive capsulitis? And another, I would like to add on another question. Our Jayaprakash has also asked about explanation of the capsular hydrodilation for the adhesive capsulitis. Okay, Nina, pass on to you.
Thank you so much. Okay, adhesive capsulitis. When I see a patient with adhesive capsulitis, depends on it's a big spectrum actually. Adhesive capsulitis is a big spectrum. So if a patient comes to you in an initial condition, we treat it conservatively like any other physician with NSAID and physical therapy. But no, if the patient has come in a later stage where there is marked adhesion, very limited movement of the glenohumeral joint with severe pain, then my preference of choice would be hydrodilation. So there's two things, actually, there's two different techniques. Hydrodilation is a little different than hydrodistension of the capsule. So hydrodilation, what we do is we inject 2 needles inside the joint. From one side, we inject whatever fluid you're injecting, a combination of local anesthetic, steroid, and hyaluronic acid from one end, and we close both the needles and create a pressure which causes the dilatation, and then release the pressure from the other needle. That's hydrodilation, as described in the textbooks or in the medical literature. There's another thing, hydrodistension, in which we can inject a little high volume inside the capsule of the posterior glenohumeral joint, which distends the capsule, as you can see visibly in the ultrasound. The capsule is quite distended, but we don't inject it in a single go. The most important clue in doing both hydrodistension or hydrodilation is that we don't forcibly inject high volume in a single instance. What we have to do is we inject small aliquots and wait. Let that volume settle in and let it distend the capsule. Then we inject some more volume and let it sit for a while and distend more capsule. So we do it very slowly, and we increase our volume till we get a good distension of the capsule. So hydrodistension you can do in a single setting. and it has a very good result with adhesive capsulitis. Hydrodilatation also you can do in a single setting, but you have to do, it takes a lot of time. So my request or my experience to young pain physicians is that if you are planning on doing a hydrodistension or a hydrodilatation to the adhesive capsulitis of the posterior glenohumeral joint, please do not inject all the volume at once, because if you do that, number one, you will not be able to achieve good hydrodissection. Number two, you can rupture the capsule if you're injecting high volume in a single go, which can cause even more pain than before. So I totally love doing hydrodistension. I mostly do hydrodistension on my patient with adhesive capsulitis. So I hope I've answered this question.
Can I add something in this answer? So hydrodistension is a very useful tool, especially in adhesive capsulitis. But I think it will be better for a young pain physician to go for a suprascapular nerve block before hydrodilatation or distension, because it can produce lots of pain. So what I usually do is combine suprascapular nerve block and followed by hydrodistension, and all precaution taken, like with a small aliquots of drug given, because patient coming to the pain clinic are usually people with the middle class and upper middle class people with which they cannot bear any pain. So as a precautionary method, I usually initially go for suprascapular nerve block either with or without steroid, and then proceed with hydrodilatation and hydrodissection. It will give you a calm and quiet patient in front of you. Otherwise, if you just go for hydrodilatation or distension, patient can be a bit annoying, and the procedure can fail also. Thank you. What is your opinion, Nina, about?
I agree with you.
Block followed by dilatation.
Yes, you always have to do block or do some sedation before doing that. So it's a very painful procedure.
So Dr. Shrish, can you also check in the Q&A box, because there are also other questions.
Okay.
Yeah.
One person, Muslik, has asked, how is suprascapular nerve block going to help for long-term pain management and relief? Isn't it a motor nerve? Which is a very good question. Nina?
So I think I would request Dr. Suresh to answer this question.
Okay. Suprascapular nerve is a mixed nerve. You are rightfully right. But it depends upon, it depends upon what thing you want to achieve with suprascapular nerve block. If it's just entrapment of suprascapular nerve, we can just release the entrapment with hydrodissection under ultrasound with just 5% dextrose and a little bit of lignocaine. And regarding the pain relief with a suprascapular nerve block, it depends upon what procedure you are doing. Like if you are giving for just lignocaine for a diagnostic block, it will really pain for 2-3 hours and pain will come back again. If you add a bit of a steroid, the duration of pain relief will be a bit more, like 3 to 4 months. And if you are going for radiofrequency ablation, yes, it is a motor nerve. You have to be careful. We cannot go for a full-blown conventional.
Well, it seems that the internet from the Dr. Shrish is not good now. The image is frozen again.
Okay, so I'll continue with the discussion. So what Dr. Suresh was saying was
radio frequency. We can give a low temperature modified RFA is even much better. Motor nerve.
Yeah, Dr. Ninadini, can you take up with the discussion?
So also, while doing the suprascapular nerve block, if you are sending the patient to physiotherapy, so I mostly do suprascapular nerve block if I want to push the patients to physiotherapy. So I do the nerve block, I communicate with my physiotherapist and send the patient to physiotherapy for the movement. Then I would, obviously, so we can always do the local anesthetic concentration. So depending on the local anesthetic concentration, we can do a sensory block, not a motor block. So I use very low concentration local anesthetic, which will only do the pain relief and not cause significant motor paralysis, and then send the patient for physiotherapy. So that way also, you can use suprascapular nerve block for your pain management. So,
Okay.
So I think I'll move on to another question.
Yes. There is a question from Eileen Chong.
Please ask me a question, Mandy. I'll just answer them.
She says that, thank you, Dr. Ninadini, for a very informative presentation and demo. And may I know which injectate do you use, the concentration, and do you mix with LA? And if yes, which type?
Okay, so that's a broad question, actually. If she had asked me about any parts that I could have answered clearly, but if I'm injecting inside a bursitis or a effusion, then I usually prefer local anesthetic, bupivacaine with a concentration of 0.25% with steroids. My choice of steroid would be triamcinolone or methylprednisolone. If I'm injecting into the muscle partial tears, I usually prefer injecting dextrose or PRP. I don't like mixing those prolotherapy treatments with local anesthetics, but I inject local anesthetic for the needling and for numbing of the patient. So that's the concentration I use. If I'm doing a suprascapular nerve block and sending the patient to physiotherapy, I use less than 0.1 concentration of bupivacaine, and I can add steroid to prolong the effect. So it depends basically on what you are trying to achieve. Okay, thank you.
Okay, so hope this answer is satisfied to Ellen. And there's another question: how to treat pain due to partial tear of rotator cuff muscle?
Okay, so if the patient presents to you with an acute tear and the pain is mild to moderate, patient is okay, then you can always opt for conservative treatment where you can prescribe the patient with a course of anti-inflammatory medicines and rest, and that will usually take care of the partial tear. But if the patient has already gone into a chronic condition with the partial tear, and with the partial tear has developed secondary other pathologies like maybe an arthritis, posterior glenohumeral joint arthritis, or a very sensitive pain, severe pain, neuropathic pain, then again, you need to treat the pain first. You need to decrease the severity of the pain. So if needed, you can do an intervention in combination with prescribing oral medications. So that's how you can treat it actually. So partial tears, if it's very small and if it is not causing much pain, in my practice, I treat it conservatively. If it is severe enough to impair daily activities, impair sleep, and impair food habits, then I intervene partial tears with prolotherapy, probably high concentration dextrose or PRP. Okay, thank you.
Okay, and there is another question: is cannot we inject drugs into AC joints only with palpation? It's so superficial.
Okay, thank you for that question. I talked about it in my presentation actually. I know everybody tends to, just palpate. It's a very superficial joint, so you tend to inject it. It's just below the skin, okay? But there's actually studies being done which have shown that when you inject by palpation method, as I had shown in my picture, if you remember, just below the joint is the subacromial subdeltoid bursa or in the supraspinatus muscle. So the depth of injection is actually difficult to do if you're doing the palpation method. If you inject too deep, you may actually not be injecting inside the AC joint. And also by study, they've seen that in, let's say, for 10 patients you injected by palpation method, only 4 landed up inside the AC joint. All the rest were outside the AC joint, probably too deep inside. So it all depends on your practice. So those are the reasons why ultrasound guidance has taken over for injection inside the AC joint.
Okay, thank you for your great answer, Dr. Ninadini. Another question is, which injection has better control of shoulder pain in case of adhesive capsulitis? And the question is, which injection has better control of shoulder pain in case of adhesive capsulitis, anterior or posterior glenohumeral joint injection?
Okay, so I'd included this part also in my study. There was a paper that I discussed where they had compared injecting into the anterior and posterior glenohumeral joint, and they'd followed up the pain outcomes, long-term outcomes in pain, reduction of pain scores. So they found that injecting into the posterior glenohumeral joint had longer period of pain relief and more pain relief compared to injecting into the anterior glenohumeral joint. So I also prefer doing it from the posterior glenohumeral joint, but sometimes knowing about approaching the anterior glenohumeral joint can be very important, especially if the posterior glenohumeral joint is very arthritic and the capsule is not outlined carefully and you can't inject inside it. That approach rescues you and you can easily inject inside the joint.
Okay, and there's another new question from the chat box from Dr. J. Can we mix a steroid with dextrose?
Okay, thank you, Jeff, for the question. Okay, so injecting dextrose with steroid is very controversial. The reason being, dextrose is an irritant. When I inject dextrose, I plan to cause a local irritation. Steroid, whereas, is an very strong anti-inflammatory drug. So what it does is it subsides inflammation. It decreases irritation. So I don't see any logic of combining dextrose with steroid. And I don't do it in my practice.
Okay. Then Dr. Shrish, you're back finally.
Yes, internet connection was lost.
Yeah, can you go to the Q&A box, because there is another question. He questioned what was the treatment given. So I don't quite understand this question. Can you take up the Q&A session for this question?
I think that the attendee is asking about that case scenario.
Okay.
Wanted to know what is the treatment given to that patient. So for that patient, we injected dextrose inside the partial tear, and with some oral analgesics, non-inflammatory ones. We didn't advise any anti-inflammatory drugs. And after a few weeks, 2 to 3 weeks time, the patient was sent for physical therapy. So I hope I have answered that question. Any more questions?
Okay, there is no...
Dr. Shrish, you can check, in the Q&A box.
There are no new question in the comment box right now. Actually, it is, I cannot see any question right now because I was logged in.
Okay. He was locked out, right.
Okay, so one question is there. One question is there, okay, Nina? So do you think 5% or triamcinolone would be more effective for carpal tunnel syndrome? Lee Chong has asked whether 5% dextrose or steroid triamcinolone will be more effective for carpal tunnel syndrome. Nina?
Okay, thank you very much for that question, actually. Okay, I'll try to answer that as much as possible. In my initial days of practice, I used to do hydrodissection of the median nerve with local anesthetic and steroid combination. But at that time, the use of 5% dextrose was not so prevalent, and there were not a lot of papers that had come in. I think after 2014, there was a paper which described 5% dextrose prolotherapy for carpal tunnel syndrome. After reading that paper, when I initially tried it in my clinical practice, I had a little hesitation. But after 2016, I have been practicing injecting only 5% dextrose into the carpal tunnel syndrome for hydrodissection of the median nerve. And I find that it has great results. It's just that the procedure may be painful for so many of the patients who have very severe pain, neuropathic features. So you can inject local to numb the skin area very carefully on the ultrasound to make sure that it does not trickle inside the very near to the median nerve. So I have been injecting 5% dextrose for carpal tunnel syndrome, and it has great results. I think the duration of pain relief which is what that matters. With steroid, it has immediate pain relief in 2 to 3 days, but the duration is very short. But with 5% dextrose, it takes a little bit more time to attain good pain relief, probably a week or 2. But after that, you have a very good pain relief for a very long time. So I hope I've answered that question, Mr.
Oh yeah, and very nicely. But I have very less clinical practice of using 5% dextrose in median nerve. I usually go for methylprednisolone instead of triamcinolone, and it has also given not all, but like there are a few small group of people who is required injection in every 6 months, but vast majority of patient has been improved with single sort of methylprednisolone. So like, but I am a bit new in care in pain practice, so I have yet to see all the effects. But like, both are equally good. You can do.
Actually, what I'm doing is I'm actually waiting for a good trial study, which compares both the studies. Then only we can come to a conclusion. Actually.
So there are now no more new questions now in my box. Okay.
Yes. So,
Mandy, do you have any question in Q&A box?
No, now there is no new one coming. So,
okay.
Yeah, thank you again, Dr. Ninadini, for answering those questions and also the great presentation. And so I think, yeah, that's all for today's presentation and Q&A session. So thank you everyone for your time to attend this meeting and make this event successful. If you have any queries.
I'll continue for.
He's back. Oh, she's back. She's back.
Okay.
Okay. So, something, your video was frozen over here. We couldn't hear you.
What about now?
Yeah, now we can hear you.
Okay, so thank you for everyone for making the time to be here and attend this meeting and make this event so successful. You see there's lots of interactions in the Q&A session. So, I need to say, so this we have to conclude this meeting. If you have any queries or comments about today's topic or any comments on the technology, please feel free to contact us or reach out to our channel partner or the academic partner, NASP. So that's all for today's webinar. Thank you so much. Thank you, Dr. Ninadini and Dr. Shirish.
So can I, do we have 1 or 2 minutes?
Yes.
Yes.
Yes. Okay. Regarding the use of ultrasound in pain practice is a very growing, there are lots of people with growing interest. And I think being a pain physician, you have to have a good knowledge of anatomy first, followed by sonoanatomy. And then if you can combine this anatomy with sonoanatomy with good USG machine like Y-Sonic, then the results will be excellent. And with the development of science and technology, our medical science is also developing a lot. And for clinical for a pain physician, I think it's a mandatory to have a ultrasound in the pain clinic. And with the ultrasound, it's not that the clinical diagnosis will be 100% right, but you'll be at least you'll be more confident in diagnosing, or the patient will be more confident in your diagnosis as he or she will be examining the ultrasound along with you. And if they find the pathology right on time, then it will be patient satisfaction will also be nice. And regarding cost also, if we use ultrasound, if you have ultrasound knowledge and if you are using ultrasound in a clinical practice, then the treatment of pain procedure will be also less expensive as well as less time consuming. So I advise all my colleagues, junior colleagues or senior colleagues to integrate ultrasound as early as possible, because it is the future in pain management, also as well as in regenerative medicine. Thank you. Thank you very much.
Thank you, Dr. Shirish, for your great sharing on the ultrasound used in pain management. And also thanks again for Dr. Ninadini for the great presentation. So also thank you for every audience, no matter in China or other the world. Thank you for attending. We hope you have learned and also enjoyed this presentation. So I think we're looking forward to the next webinar.
Next webinar, both Nina, Dini, and I am very much eagerly awaiting, because this was our first date. I think if there is any problem, we'll make it better next time. Surely we'll make it better. And we are planning to go to do these webinar of other joints, MSK, which is useful for pain. Thank you.
Yes, yes, sure. Thank you. Thank you all. That's all for today's webinar.
Thank you.
See you. Bye.
Bye. Bye.
Bye. Bye. Bye.